We're in an era right now in AML where we're kind of almost an embarrassment of riches, where we have a lot of new drugs approved just in the past few years, and I really am encouraged by some of the data, and hopefully we'll have new drugs and more drugs approved. The more tools we have in our toolbox, the better we can identify the right drug and pair it with the right patient based on their own genomic profile, based on their own individualized phenotype. So I think one of those areas is FLT3 inhibitors. The first one to be approved was Midostaurin in combination with 7+3 in the frontline setting. We now have data from the Quizartinib trial, Quantum First, which shows a significant survival benefit of 7+3 with Quizartinib compared to 7+3 alone, hopefully allowing this to be approved in the frontline setting. Now we have two options in the frontline. Additionally, we have Gilteritinib, which is a single agent, showed benefit in the relapse and refractory setting. And obviously there are studies ongoing right now in combination with low intensity therapy, with the HMA-VEN backbone, as well as intensive chemotherapy in the frontline and relapse setting, all showing dramatic outcomes in early looks at these studies. I think when you approach a patient currently in the frontline, hopefully if Quizartinib does get approved, you may have a choice. And I think that you make the choice of what FLT3 inhibitor you use based on the phenotype of the disease and the phenotype of the patient. If Quizartinib is approved theoretically, it has potent activity against FLT3 ITD, but not much activity against D835 or a point mutation, whereas Midostaurin, a type 1 FLT3 inhibitor, will target both. So in a patient who has a large D835 or point mutation clone, or one who has both, I may consider Midostaurin over the Quizartinib, whereas in someone who had an ITD alone or a large ITD clone, I think Quizartinib would be my first choice. That's sort of disease related. In terms of patient-related, Quizartinib has issues with QT prolongation that we've seen. And so someone who has issues, cardiac issues, baseline QT prolongation, abnormal electrolytes, which I'm not able to correct, you may want to be more safer and consider a Midostaurin-based approach and avoid the potential toxicity you may see with Quizartinib. So those are some of the ways where we can choose if we have more drugs available. In the second line setting or the relapse and refractory setting, the only labeled drug we have, of course, is Gilteritinib, which again is pretty well tolerated. There is some liver toxicity to watch for. There is myelosuppression when you combine it with other chemotherapy, but that's essentially the approach. As more drugs come, I think we really need to identify what matches the patient based on the patient's underlying comorbidities, their overall shape, and then also their disease, which target is exploitable by that FLT3 inhibitor.